You're live, Chair.
Good evening and welcome to this meeting of the Overview and Scrutiny Committee, meeting on Tuesday, the 15th of October. My name is Councillor Simon Morgan and I'm the Chairperson of this committee. Members, we are streaming this meeting live as well as recording, and by being present in the meeting, you are giving your consent to being recorded. During each item, please put your hand up to indicate if you wish to speak. I will then invite you at the appropriate time. Could I ask members to avoid approaching the top table, as this could create interference with the cameras and live stream. Please note that the YouTube live stream sound recording is dependent on the correct use of the microphones. Therefore, can I ask that when invited to speak, you remember to turn on your microphone and turn it off when finished. Please reference a page or a paragraph number when referring to the agenda papers, and keep your contributions as clear and concise as possible. So, moving on to item 2, apologies for absence. May I have apologies for absence, please, Sean?
We haven't received any apologies for absence, Chair.
No, I think we've got a full house, which is good. Okay, moving on to item 3, minutes of the last meeting. It is recommended that the minutes of the meeting held on the 24th of September 2020 and found on pages 5 to 10 are approved as a true and accurate record. I so moved. Have a seconder? Councillor Spenceley. Is that approved by consent? Agreed. Thank you. And Sean, congratulations on those minutes. I thought that was a very good summation of what was quite a possibly interesting meeting. Thank you very much for that. To be commended. Moving on to item 4, declarations of interest. To disclose the existence and nature of any disclosable pecuniary interests, other registrable interests and non-registrable interests relating to items of business on the agenda, having regard to paragraph 9 and appendix B of the Code of Conduct for members. Members are reminded that they are also required to disclose any such interest as soon as they become aware, should the need arise through the meeting. Has anyone any interest they wish to declare? No, thank you. Then moving on, item 5, public participation. As far as I'm aware, Sean, we have not received any submissions from members of the public. Is that correct?
That's correct, Chair. No requests have been received. Thank you.
Okay, thank you. I'd also like this evening to welcome Councillor John Driver to join us, and also Mr. Dodden, and I'm sure we all join in congratulating him on his new appointment as the Deputy Chief Executive. Well, so, without further ado, let us move on to item 6, the Mid and South Essex NHS report, and a very warm welcome back to Daniel Docherty, the Mid Essex NHS Alliance Director, who is to give his presentation. Over to you, Dan. Thanks.
Thank you, Chair, and good evening, everyone. So, there's a number of different parts of the kind of presentation this evening, and if it's okay, Chair, what I'd suggest is we maybe take each part in turn and then maybe take the questions on each section separately. I'm now realising I've got to move these two things separately, given what I've said about my eyes earlier. But one of the first things that I thought would be useful to talk to you about was, I guess, the macro state of finances within the NHS in Mid and South Essex. And you probably heard and you probably read that the NHS in Mid and South Essex, indeed nationally, is very much up against it financially, and that is absolutely true for our system. Our system is in a very sort of precarious position at the moment. Some of this you'll have seen in the statements that Wes Streeting made. He used the term, didn't he? The NHS is broken at the minute. Subsequently, Lord Aradazi has produced a report as well, which has highlighted some of the problems that the NHS is facing. So what we're going to talk about here is a little bit around the context about the financial challenge, the nature of some of the challenges themselves, and then some of the actions that we're taking to try and address those challenges. So in terms of the context, there's no one single reason why the NHS at the minute is up against it financially. It is a combination of multiple different factors. Population growth is significant, and as it says there, we're looking at sort of 15% over the next 15 years. That's on the backdrop of the growth that we've already seen. You guys will know this district as well as I do, but we've started to see increasing growth in this district. It's true across Mid and South Essex generally. Chelmsford, Braintree, all significant growth. all of that impacts on NHS services. That said, the demand then that generates on health services is actually outstripping the growth in the population. So despite although the population is increasing, the demand that's then subsequently placing on the NHS, but also social care services, is increasing even more quickly. And in part, that's because the population is ageing. And we know that as the population ages, older people generally will consume more health resources, more social care resources than younger people. So that has an impact. But the other reason is that the NHS tends to innovate, and it's able to treat things today that it couldn't treat a couple of years ago. New treatments come on board that the NHS then offers that perhaps it didn't historically. And an example of that that's very current at the minute you'll have seen would have been these weight loss drugs that are coming out. It's a new range of treatment that can potentially tackle something, so it opens up new avenues of opportunity. At the same time, we've seen challenges within the workforce, and we're talking about GP workforce later, so I won't specifically go into GP workforce, but we have less doctors and nurses than what we did. A number of particularly older doctors, nurses, therapists retired post-COVID. It brought a sort of swathe of retirement within the NHS. But we've also seen a number of our doctors, nurses and therapists move abroad and go to other places, and some of that compounds the challenge with the NHS, but it becomes almost a sort of self-fulfilling prophecy. The more demand that there is, the harder it becomes to work in the NHS, more likely people are to leave. So lots of those things. And then the final thing that it relates on there is the cost of living, and that is having an impact. And again, we know that the impact that cost of living has on people's opportunities for positive health behaviours, winter warmth, nutrition, all of those things can be impacted upon by the cost of living. So all of these things are compounding to increase challenges on the NHS in the backdrop of the pandemic, which we know had a massive impact on waiting lists and things as well. So so much that's happening at the minute that's contributing to that challenge. So the next slide then talks about the nature of funding for the NHS, and a lot of people again don't necessarily know this, but ultimately the Secretary of State confirms a budget for the NHS for England, and it shows it there about 155 billion. That goes to an organisation called NHS England, which oversees the whole of the NHS in England, and it allocates the bulk of that money out to ICBs, of which Mid and South Essex is one of those ICBs. Some of that money, though, a smaller proportion, you can see it there, 25 billion, goes direct to the NHS providers, because there are certain services that are large scale that are not contracted or commissioned locally. They're done on a much grander scale, specialised services. So things like the services that you might see in Broomfield for burns and plastics, they're commissioned on a wider footprint than just our local footprint. Likewise, Great Ormond Street would be a good example. Highly specialist services to treat these really rare, unique conditions, those sorts of things commissioned there. The money that we have as an ICB, the lion's share of that goes out to our providers, of which our biggest one for us is Mid and South Essex Trust, which runs Broomfield Hospital, Basildon Hospital, Southend Hospital and other sites. The next layer in that, I suppose, would be our mental health providers, EPUT, Essex Partnership University Trust and NELF, so different NHS providers. And then an element of it goes out into what we would then call primary care or primary medical services, which is, we use the term POD. So if you ever hear us use POD, apologies, but that stands for pharmacy, optometry and dentistry. And then primary care, as most people would see it, GPs. So when you go and see the optometrist, when you go and see an NHS dentist, all of that now is commissioned locally through your ICB. So that's how money flows. In Mid and South Essex, what does that equate to? Well, it equates to around about £2,000 per head of population. That's roughly what we're getting. And we're about 1.2 million population in Mid and South Essex. So our budget's around £2.5 billion that we get. So it's a substantial amount of money that comes through. So that's just how the money flows. Now we're talking about the financial challenge that we face. And the reality for us at the moment is that our expenditure is outstripping our income. We're spending more money than we get. And if we did nothing as things stand at the minute, we would probably be spending somewhere in the region of 250 million pounds more than what we're allocated. And the expectation from NHS England and ultimately the Department of Health is that we need to do things to address that, because ultimately we're living outside of our means. At the moment, we're predicting a system-wide deficit. It says there of almost 60 million. Actually, on checking our latest board papers, and this is where I was saying I'll update the slides, that's now more likely, we've reported recently, going to be more in the region of 90 million, 94 million, so that kind of region. Now, in order to do that, remember I said we were outstripping it by about 250 million. That means we've got an ambitious internal savings programme where we've got to generate an efficiency of about 150 million pounds. Now, remember when I said about that overall budget, remember I said it was about 2.5 billion overall? 250 million, it's not far off the region of 10% of our budget that we've got to try and save. Now, we can't do that in one swoop, and the expectation isn't that we do it in 1 year, but the expectation is certainly over the next couple of years that we get ourselves back into balance. Now, that creates significant challenges for us. What it also means for us is that Mid and South Essex Foundation Trust has been put into the highest level of national oversight in terms of scrutiny of, I guess, our grip and control of finances. So the term that you'll hear NHS folk here is NOF4, but NOF stands for National Oversight Framework, and there are different tiers of oversight. And I guess the more challenged you are, the higher up the tiers you go, and we are in the uppermost tier. Now, you can look at that as a bad thing, and it's not a place that you want to be, but at the same time, it does bring with it a level of support and acknowledgement from the centre that your challenge is great. And as part of that, we do get support from consultancy firms who help to check our kind of grip and control and our methodology and the way in which we're spending money to ensure that we're trying to do everything as efficiently as possible. But as it says at the bottom of that slide there, doing nothing is not an option. There is not an expectation that our system will just continue to spend beyond its means. There is an expectation that our system addresses the deficit and brings itself back into balance. So in essence, what we've had to do, and I appreciate those of you that work in local government, this is something that's very familiar to you guys, because you guys have experienced similar challenges over the years as well. But we've had to create a programme that ultimately increases value, it reduces waste, and it cuts costs wherever we possibly can do it. And it spans all of the different bodies within the ICB, the Integrated Care Board. The bulk of that programme sits within our foundation trust, so for us, Broomfield, Basildon, Southend, because that's where the bulk of our spend sits. But as I said previously, other organisations, EPUT, our mental health trust, they have an efficiency programme, and we as an ICB, we ourselves have a savings programme that we need to generate. And then people often say to me, well, what do you spend money on? Well, we spend money on staff, but we also fund for example, the drugs budget of GPs. So if we're prescribing more medication or wasting medication, that's a cost to us. We also fund something called NHS Continuing Healthcare. Now, a lot of people are uncertain of what this is, but you find people often find out later in their life. This is where somebody, as a result of their health condition, needs ongoing care within either their own home or a nursing home or a residential home. This is out with social care, so it's as a result of their health condition. And these can become incredibly expensive, particularly imagine you've got somebody with a particular kind of neurological disorder, maybe they've got difficulty breathing, they need 24-hour care, they need feeding. That is funded by the local NHS, and those costs at the moment are spiralling. So ultimately, what we're looking to try and do is to create more efficient, more streamlined services, and wherever possible, not compromising on the quality of care delivered. What we will never do is compromise on the safety of the care delivered. When I say we're trying not to compromise on the quality of care, in some cases the quality of care is reduced somewhat. It may be that a waiting time extends, or it may be that the depth or breadth of a treatment offer can change. And that's us trying to balance where we're putting our money to get the best returns for the population. So in terms of the kind of roadmap, there are 4 key areas that we're looking at. So corporate efficiencies would be familiar to you guys. This is our sort of back office functions. Are we getting the best possible value out of every single back office function that we can get? We are guilty of, for example, having different IT support would be a good example in the different organisations. We have different clinical systems, we have different HR systems, and we know that if we can unify those things more consistently, that we can extract value. Again, something that's familiar to you guys in local government. We then have our planned care programme, and for us planned care is all the kind of pre-booked appointments, and Paula, something like cataracts would be within planned care. We've got huge backlogs of treatment for hip and knee surgery, eye care. Cataracts is a good example, but even things like physiotherapy or autistic spectrum assessments, lots of those things are stacking up. How are we managing that backlog? Are we getting the best value out of it? And actually, in a positive way, the NHS England and nationally, you're actually incentivised in that if you can become more efficient and get more operations in, or get through more procedures or more diagnostic tests, you actually can be rewarded by financial sort of incentives. So you can actually gain money into the system by demonstrating that you're more efficient. So that's what the planned care programme is. We then have what's called our out of hospital, our independence programme. This is essentially keeping people well and stopping them from going into hospital in the first place. And we will touch a little bit on this when we talk about winter in a moment. And then what we call our unplanned care or our flow programme. And this is one of our biggest areas. This is essentially where people are unexpectedly usually admitted into hospital and then enter into that hospital-based system that many of you will experience, where we're trying to discharge them from hospital. Maybe they're not suitable for going back to their own home, and then they enter into that care system that becomes incredibly difficult to navigate and often introduces significant delays into people's pathways. If we can improve all of those things, then we can take out significant costs, but more importantly than any of that, we can give patients better outcomes. So many of our patients sit in a hospital bed when they don't need to, because they can't get into their own home for a particular reason, or because we can't get them into appropriate nursing or residential accommodation. So if we can streamline all of those processes, we reduce costs, but as I say, more importantly, we give people a better opportunity and a better chance of recovery. And then the organisations are there, as we've spoken about in a moment. So just in terms of actions, and then I'll stop for questions, things that you might see that we're doing, you might see changes, and this is important for you guys because the public may see some of this. Sometimes do see changes in the types or volumes of medication that we provide. I take a medication called omeprazole. It's for gastric reflux, acid indigestion. And interestingly, when I get it from the GP, quite frequently, month by month or week by week, it's a different manufacturer. So sometimes I get one pill packet, sometimes it looks different. Why does it look different every time? People say, why don't? Actually, the costs vary. It's almost like a stock market, the drugs market. So occasionally one particular manufacturer of a drug will be more expensive than another. If we can then get GPs to switch to that new one very, very quickly, and we've got programs and computers that can do those sorts of things, then actually we can save money. Now, for a patient, sometimes, why do I get why do I get the blue and white ones this week, but the red and white ones next? That's the reason. It's trying to balance cost. This is significant for us. We've really strengthened our governance processes, but particularly in terms of spending money. And we've now got a thing called a triple lock. So in essence, me and my organisation as a director, if I want to spend money, we have a scheme of delegation. I can authorise certain payments. But now those payments then have to be signed off by a board, and then they have to go through a third layer of scrutiny within NHS England to be signed off. Below certain values for operational stuff we get away with, but I'm talking significant spend. And this is now where you have an increased layer of challenge. We've actually reduced the number of people in our organisations that can authorise payments as well. And this is a delicate one to get right. But in hospitals over the years, we've probably pushed the ability to spend money out closer to the front line. And actually, I've heard it quoted that we had maybe 800 people within our organisations that could authorise significantly large payments. And actually what we've tried to do is reduce that number, almost half that number. And what that's trying to do is get more grip and control to make sure that we're only spending money when we absolutely have to. And that would be particularly when we're using, for example, locum staff would be a really good example, like agency staff. Is it absolutely necessary this time? I spoke about this briefly before, overperforming against our recovery target. If we can utilise our theatres more effectively, we essentially get an incentivisation payment that can be beneficial. And then particularly reducing our utilisation of beds, particularly during the summer months when we can reduce admissions and reduce our dependency on beds, because staffing beds unnecessarily costs us money. Couple more things there. Again, many of these will be very familiar to you. Looking at all of our contracts that we have and ensuring that they're market tested and that they're value for money. The NHS, as you would imagine, has hundreds of subcontracts with different providers, be that in the IT areas, be that in cleaning, be that in servicing equipment, be that in looking after buildings. All of those things, the more we can market test those to ensure that we're getting optimal value for money and the right service, the better. Treating people in the right place, we spoke about that a moment ago. And then, I guess, in some respects, reprioritising our teams to focus a little bit more on financial recovery. And this is something that Paul has seen firsthand, because we were doing an awful lot of work, outreach into communities. We were particularly doing some fantastic work, and still are, in fairness, with the One Maldon Board and Maldon District. But actually, the NHS has perhaps reduced its contribution to that at the moment, because we're focusing on trying to get our financial recovery programmes on track. What we're blessed with in the Maldon District, and certainly in my area in Chelmsford and Braintree as well, is that we've got partners, including district councils, county councils and our voluntary sector, who are actually helping to further that work, so that burden isn't now falling solely on the NHS. And I think that is one of the strengths of the One Maldon partnership that's developed over the last couple of years. So I think at that point I'll stop on this one and say if there are any questions on financial recovery before we move on to talking about GP workforce.
Thanks, Dan. Before I throw it open, perhaps you could help me a bit on some acronyms. So we've got the Mid and South Essex Foundation Trust. We've got the Mid and South Essex Intermediate Care Board. Integrated Care Board. And we've got the Essex Partnership University NHS Foundation Trust.
Correct.
Can you just, the certainly benefit of me, perhaps I would suspect other members, just explain how those three sort of fit together?
So the NHS is always fond of three-letter acronyms, and I'm probably on about my fourth or fifth now. So the ICB, the Integrated Care Board, I guess is the overarching organisation of the NHS that receives money from NHS England and distributes that across providers for Mid and South Essex. ICB's replaced what were previously called CCGs, and we had 5 of them in Mid and South Essex. I worked for the Mid Essex one, which was Maldon, Braintree and Chelmsford, but we also had Basildon and Brentwood, Thurrock, Southend and Castle Point in Rochford. They were abolished a couple of years back and replaced by a wider, bigger organisation called an ICB. Prior to CCGs, some of you will remember PCTs, and some of you will remember that we went back, we had Maldon and South Chelmsford PCT. Prior to that, we had PCGs, primary care groups, and we had a Maldon and South Chelmsford, one of them. So they've evolved over time. So the ICB is that overarching sort of body that receives the public funds to distribute. You'll hear other terms, ICP, Integrated Care Partnership, that confuses people, but that in essence is not just the ICB, but wider partners that have a role in health and well-being across an area. So our ICP meetings, for example, Paul attends as a representative of local government. We have Essex County Council attend, we have Anglia Ruskin University attend, we have various people attend who are part of a wider partnership that can impact on people's health and well-being. And then to further confuse things even more, people tend to refer to that whole collective thing as an ICS, an integrated care system, and that's right. Everything together. But I'm actually employed by a thing called an ICB. So then we have our providers, and for us, we've actually got a number, but the NHS really only focus on the ones that they say are part of your core system. And they refer to them as also contributing to what they call our control total, which is where they look at who's spending money within our system. And I'll relate to this in a moment, but the 2 major players for us in that are Mid and South Essex Foundation Trust. Now that is the foundation trust that provides acute services. So for us, that is Broomfield Hospital, Southend Hospital and Basildon Hospital. They were independent. So for us, that used to be called, now I'm testing myself, So Basildon Brent was Basildon Brentwood University Foundation Trust. We had Mid-Essex Hospitals, MEHT. That wasn't a foundation trust, that was Mid-Essex Hospitals Trust. And then Southend Hospital, it was called SHUFT, Southend Hospital University Foundation Trust. The three of those merged, you might know when they merged about 4 years ago. Yeah, sort of 4 years ago now, 5 years ago, and they created a single entity called the Mid and South Essex Foundation Trust. So that primarily does acute services. So if you think what that is, it's surgery, A&E, outpatients, diagnostics, those sorts of things. Then we have one called Essex Partnership University Trust, EPUT. That provides primarily mental health services. So all of our acute mental health services, inpatient beds, outpatient mental health services, but for parts of Mid and South Essex, particularly towards the south of the area, it also provides community services. So things like district nursing, community physiotherapy. There are two other players in our patch that don't contribute towards our control total. So in Mid-Essex, we have an organisation called Provide. I don't know if any of you, some of you will know Provide. Provide does a lot of our community services, but because it's a community interest company, it isn't seen as being part of the NHS per se, because it is somewhat independent because of its form. We also have an organisation, a North East London Partnership Foundation Trust. They provide mental health services in our area, but because fundamentally they're based in North East London, they're considered to be and processed by the NHS, for want of a better term, as part of the North East London ICB system. So they do provide services in our area, and they do play a big part in what we do. But actually, in terms of just dividing things up, their overall finances are looked at as part of North East London, which is where their kind of base is. So I suppose fundamentally for us, the biggest players are the ICB itself, who I work for, the hospitals, MSE Foundation Trust, and EPUT, our mental health and community provider.
Thank you very much. That's very kind. Right, so members, open to you. Councillor Stevens.
Thank you, Chair. Yes, you did mention this. I wonder what progress there is on bringing all the systems together, because I think members would be surprised to realise that there isn't an A&E system for every NHS trust up and down the country, or a radiology system or whatever. That absolutely isn't the case. There are dozens of them, and different trusts use different systems. And then, of course, when trusts merge, but they're using one radiology system and they're using another, that doesn't work too well. So I just wonder what progress there is. And you mentioned that you're aware there are still disconnects there. So I'd be interested in that, please. Thank you.
So absolutely right. And for members, not only are there just not one system, there are hundreds of systems. In some hospitals up and down the country, it's being assessed, there are literally hundreds of different IT systems. You might have a different system for radiology, to theatres, to outpatients. You might have a different cancer system to dermatology system. And that is an element of the evolution of the way that computer systems have happened within the NHS. There's also the kind of plurality of the market, and often we had to go out to tender for different systems, and that led to lots of different players in different marketplaces. And it's not just true of hospital systems, it's true of out of hospital as well. There are probably 3 or 4 main GP systems up and down the country, although we are very, very blessed in Mid and South Essex, and particularly Mid-Essex, in that now in Mid-Essex, and certainly in the Maldon district, all of our GP services are on the same system, massive. But again, real diversity out there. There is an ambition across the whole of the NHS to start to unify these systems. Now, in many cases, that doesn't always mean moving all services onto the same system, but what it does is it means sort of putting umbrella systems across the top that are able to pull from, for example, the ambulance service, A&E, the GP record. So you'll hear of 2 or 3 main kind of programs around that. One is a concept of a thing called a shared care record. So a shared care record, and again, a lot of patients don't understand why we haven't got this already, but there are lots of governance and information governance hoops to go through it. But the shared care record concept essentially says that there will be a unifying system that sits over and above all the other kind of systems that you and it will suck up the most appropriate information and the required information, so that if, for example, I get found knocked out on the rugby pitch down at Maldon and the ambulance comes to pick me up, the ambulance team can go into the computer and see that my GP prescribed me with a particular type of medication yesterday because it's in my shared care record. They can see that I've got an allergy to a certain drug that they might prescribe, but they now won't because they can see it on the system. Alternatively, if I go into A&E and I'm elderly and confused, they can look on the system and see all the medications that my GP's prescribed. They can look at the test results that I had a few weeks ago in a different hospital because I'm visiting relatives, those sorts of things. We're not there yet, but in Mid and South Essex, we've got a significant programme and an investment into a shared care record system that will deliver many of those things. On top of that, though, you'll hear another term that we use. I told you we like three-letter acronyms. So shared care record, SCR, EPR, electronic patient record. This is whereby in hospitals, hospital systems now, remember some of you must have been to a hospital and seen your own notes. If you're blessed with not going to hospital very much, it's a very thin thing like this. If you've ever visited someone who's been to hospital lots of times, those notes can be volumes and volumes. The aim has been to transition all of those paper-based notes into an electronic system in hospitals for years. And there are different systems up and down the country provided by different big manufacturers. You've heard all the major kind of IT players have often got clinical systems. And Emma's absolutely right. They've got a different system in Broomfield to what they've got in Southend. So if I want to log on to my computer in Broomfield, I log in, I've got to log in, I can see a particular record. If I then go as the same doctor to Southend, I've not only got a different system and a different login, but it can't see everything that I've done at Broomfield. It's a real problem. Now, these systems cost millions and millions of pounds. Again, we've got a programme in Mid and South Essex whereby our hospitals will go onto one unified electronic patient record system, but it's a big transition to make and we're on the road to do that. What I'd suggest, if possible, I kind of feel like that would be a really good update because I don't know all the dates and timelines for all of it, and my apologies, but I think what I could do for certainly a subsequent one of these is come back and actually do a focus session on those things. I think it would be very interesting. I could probably bring someone who's a bit more expert at IT than myself, but the ambition is there, absolutely, as you say, that we will have a single electronic patient record within our hospitals, and it will stem our mental health and community provider, which will be for clinicians. I swear to God, when they turn it on, you'll hear them rejoicing. And then likewise, we will have a shared care record within this system. The final thing I wanted to say about the shared care record is the ambition with those as well is that they have what are called patient portals, which is where patients themselves can log in then and look at their own clinical records and be able to share their own clinical records, and that's part of that programme. But I suggest we maybe go into a bit more of a deep dive on that in a future one, and I can get a bit more information.
Okay. Let's just hope it's not called Horizon. But anyway, let's move on. Councillor Morley. Oh, sorry, I do apologise.
I've not got much to say, but just to say that would be really useful, and if it can be in the context of the finances, because it's great to have huge, marvellous ideas, but the financial strategy, I think people tend to just say, oh, a contract's expiring next week, we better do something, and that's not strategic at all. So if it could be in the context of the strategy and of where the patient sees the impact. So I think I mentioned to you at this meeting last time that Tollesbury patients' blood tests are going off to a lab in Ipswich. The patient's going to Broomfield Hospital. They can't see the Ipswich lab results. And I know there's something coming on that, but it's that sort of thing that if we need to look at it in terms of what's the patient impact, how does it affect our residents, and when will they see change?
And Emma, to put that even more sort of in the patient sphere, many of you know I'm a physiotherapist. I'm a working musculoskeletal. I've seen instances where people have come and seen, for example, a physiotherapist or a surgeon with back problems and said that they've had an X-ray somewhere. And because of that failure to link systems, we've not been able to see that X-ray in a timely way. So what have we had to do? We've had to repeat the X-ray. It seems obvious. It doesn't take very long. People say it's only an X-ray. It doesn't take very long. It does two things. Yes, it has a cost and it has an inconvenience to the patient. But actually, an X-ray of your lumbar spine is exposure to radiation, and you don't want to expose people to radiation any more than you need to. We have a rule in imaging within the NHS that essentially says we should keep doses as low as is reasonably achievable. Now, actually, you'd argue that if somebody's already had an X-ray in one part of the country, you shouldn't have to repeat it somewhere else. So it's not only more efficient, but it's safer for patients. So it is absolutely the right thing to do. And it will help us with our financial efficiency. It will make life easier for patients, but it will also give patients better and safer outcomes, which ultimately is the most important thing. So absolutely agree.
Councillor Morley.
Yes, thank you. You picked up on staff leaving and doctors and things like that. Excuse me. I just wondered how that's affecting the service or the cost of training doctors, and are they contracted to work for so long, or once they go to Australia or whatever, that's your lot? So you've trained them for 6 years or whatever?
Sadly, the latter, yeah. And so hence trying to retain staff is a big emphasis up and down the country at the moment. We are very lucky in that we've now got Anglia Ruskin Medical School. We're starting to see the first graduates come out of that. There's a big focus on Anglia Ruskin on primary care, so general practice, which is unusual. Most medical schools are, as you're probably aware, are linked to big hospitals, hence they're called university hospitals, as we were explaining. So you tend to see them around, the Royal London or Barts or whatever they tend to, whereas Anglia Ruskin has got a focus on kind of primary care, which is fantastic. We've got a number of schemes. I'll touch on some of them later, actually, around primary care, about what we're trying to do to, I guess, retain and support our doctors and nurses and therapists. It's not just doctors, but yeah, absolutely. It's a major part of what we're trying to achieve. And it is, and it's disheartening when you see. It doesn't matter whether they go abroad. Some leave the profession entirely. Some go into other professions. Some go into private practice solely, and it is disheartening because generally it is the NHS that invests in training those staff. But I think we're increasingly now realising that we've got to, make these jobs attractive, make these jobs enjoyable, offer opportunities, training, and there's a big focus on that, some of which I'll touch on in a moment, so I'll come back to that.
Because some things, but in the army, you have to sort of stay in for a while, don't you, even if you've been trained up. So I just wonder if there's any kind of thing in the pipeline to...
So there are schemes like that. When I trained as a physio, I was in a very lucky time when the NHS actually funded my fees, and you were there were sort of, I don't know what you call it, but stay for 3 years, leave early, and you refund. You have to pay a bit of your costs as well, and some do that with training and things. But in some cases, it's down to individual choice. There are some linked schemes though, where people essentially go on a kind of a tiered basis for the training that they get. We've got other schemes that link to overseas recruitment and things like that, whereby people have got to, I guess, keep up with the various kind of training that they need to do to register in this country. So language training, for example, would be a good example. So we've got doctors that we recruit from abroad, we take them through a programme, and it's only when they complete the programme then that they can be employed. So there are certain schemes, but it's difficult at the minute. And this is not me saying this, because this has been reported by the Secretary of State, it's been reported by the Darcy report, but morale in the NHS is quite low at the minute, and I think lifting the morale is going to be a big thing. Like, a lot of people feel quite battered and bruised at the minute, which is obviously creating a challenge, and when you add all this sort of financial pressure in, it kind of compounds the problem, so it's significant.
Councillor Thompson.
Thank you, Chairman. Dan, that sounds like an alarming number of reorganisations over the last few years. And as we know, as well as saving money, they cost a fortune. Do you think the ICBs are going to be with us for a while? Have you any way of knowing where you're ball better than mine?
I mean, I've now been in the NHS long enough that I've been through probably 4 major ones. All I would say is at the moment we've had some very clear statements of intent from the new government. The Darcy report, I think, is clear in what it sees happening. There's a big focus on primary prevention, so trying to work. The term that you'll often hear in the press or in the NHS at the moment is left shift. or upstream. And what they mean by that is trying to treat people before they get sick. So we were talking about strokes at the start. If you can treat people and find people that have high blood pressure and treat their high blood pressure, if you can treat people that have got high cholesterol and reduce their cholesterol, people who are overweight and reduce their weight, you reduce strokes. The argument is it's far better to work upstream or left shift than it is to just think, well, we need more people to treat strokes. So that's very much the kind of the narrative that we're hearing. Whether that is going to require a reorganisation to achieve that, I don't know. I think that we wait and see on that. I think one thing the NHS has learned, and I think you're right, is that reorganisations themselves can become a distraction. We've got a task in hand. We've got a financial task. We've got the challenge of health within communities that we all know about, the demand that's out there. My hope is that clarity is given around the ask, but hopefully we don't distract ourselves. But I honestly don't know. I don't know at this point.
Councillor Driver.
Thank you very much, Dan, for the presentation, which was very interesting. I want to just sort of step back and take a sort of bigger picture view, if I can anyway, because you point to a lot of the issues that sit within the NHS, and I think we're all aware of a lot of those issues and the complexity. But it feels like this area has been hit particularly hard with some of the issues that are facing the NHS. And you've already alluded to the position financially of the local ICB, and one might read into that some problems that arose in the history of arriving at the present ICB and problems in getting to that point, which has resulted in us being in a more difficult financial position than other places in the country. And I think actually, if you look at a lot of the indicators relating to this area compared to other areas across the country, we don't do well. And I think that's a problem. And I think a lot of people are concerned that actually, we are at the end of the list in terms of what we experience and what we get in the Maldon district. One of the issues, it seems to me, about a focus, which I understand, on the finances, and I can see that is needed, but the danger is that it becomes very finance focused, and you can make decisions that in the short term result in savings, but are more expensive in the long term. And actually, the short term gains produce some fairly significant long-term consequences to health provision in an area, which then, costs a lot more to then put right going down the line. I wonder if you'd like to say something in response to that. Just
No pressure.
I mean, I think you articulated the challenge that we face. Absolutely. I think a couple of things I would say. We have a number of safeguards in place. So any decision that we make, we have to undertake a number of kind of assessments. But in particular, I would highlight things like equality impact assessments, privacy impact assessments, those sorts of things. Significant decisions will always go through a clinical panel as well. And the most significant one that I would highlight for you is what we call a quality impact assessment. So in essence, if we are going to make a decision, whether it's for a financial saving or any other reason, a group of sort of independent clinicians that, trust me, are not going to put finances before safety will assess that decision and try and highlight some of the risks that you've alluded to there. And you're absolutely right, though. It is an element of balancing, in some cases, some of those risks, short-term gain versus long-term pain you described. Equally, sometimes the preventative agenda requires investment today, but you don't necessarily see the benefits for a number of years. And trying to get that balance right is incredibly difficult. I think, and I don't say this glibly, I also think having that conversation transparently with partners is important, and included within that I include the population themselves. I think we need to be clear with patients and the public, because we're talking in some instances about people, the services people may receive before they're considered a patient even. I think that is an important conversation that we need to have, and I guess being here tonight in some ways and being able to talk about financial recovery for me is a positive thing, because it hopefully now means that you guys are understanding a bit more about NHS finance, and people I know will ask you questions. They've elected you for that purpose, but hopefully you can understand some of the decisions and help explain it, because I do think the public will see changes in the NHS. Will we get it right every time? I don't know that we will, and you're right, Essex has been challenged for some time. I think we some of you will remember this because I was part of it. We were designated a thing called a success regime about 7 or 8 years ago. It was ironically named, you could say, the success regime. But the rationale, there are only 3 parts of the country that went into that. And the rationale for Essex was a history of complexity, basically. 2 unitary authorities, Southend and Thurrock. Essex itself, we were historically 7 CCGs. Some local areas have historically had 1 CCG that covers 1 county with 1 hospital, and it's now 1 ICB. Even now, we've got 3 ICBs covering Essex. We've got Colchester, exactly the point that Emma made. People up in the north of our patch, north of mid-Essex, but you could even go to the north of Maldon in this instance, you're talking about Tollesbury, actually will often migrate towards Colchester. That's in a different ICB at the minute. So we are a complex system. It's an impossible question to answer as such. I think the challenge that you highlight is one that is very familiar to everybody within the NHS at the moment. I would also say that we are a system that has been through financial recovery several times before, and I don't think anyone in this system that's been around for a while wants to repeat some of those historic mistakes that you've alluded to, where you strip out large swathes of clinical infrastructure that ultimately can lead to, in some cases, decades of service challenge going forward. So I think it's the efficiencies that we've referred to in terms of back office, financial grip and control, procurement, those sorts of things that can really deliver and hopefully not compromise frontline services. But it's a very relevant point.
Okay, Councillor Spencer, then I think we must let Dan move on.
Just a really quick question, because I'm curious about this, Dan. So with regard to when you're looking at financial strategies and the decisions that you make going forward with regard to any specific number of areas, and I don't want to get too involved in that in terms of our own area at the moment, but looking at it across Mid and South Essex, you talked earlier about the strain that's put onto the NHS by the growth in population, and obviously this part of Essex, like elsewhere, there is huge growth. And I'm just thinking of how we, for example, as a local authority, work with education, let's say, at Essex, and look at, when they plan facilities and they plan what services they'll deliver in an area, they have they look at the growth that we have and what's actually been built out. And is that a consideration when all of this financial recovery work is going on? Is the NHS locally, is the ICB factoring in the growth? Because one of the things, of course, that occurs to me is that under, for example, the new government at the moment, we're waiting to find out about proposals that would see our growth double pretty much. And in fact, we were already very recently building out 153% of our national target. So bearing all those things in mind with regard to growth, and also Chelmsford, which has hugely increased targets, do you sort of, when you're coming up locally as an ICB with financial recovery strategies, think about which hospital will need more, where you'll need more services? Does that factor into your plans to make them more robust in a long-term way? I just wondered if that's part of it.
Yes.
It's
a simple answer.
Does
the NHS plan for growth? Yes, absolutely.
It does, you do.
There would be no way that we couldn't. Our A&E now sees probably 100 more patients than what it did 7 years ago. If we didn't plan for that growth, they wouldn't be seen. We wouldn't have the capacity. We need to plan for more ambulances, we need to plan for more staff. I think two things. The bulk of what I talked about here is revenue cost. It's the ongoing operating cost of the NHS. Capital is a slightly different conversation. But do we plan for growth? Absolutely. I think the challenge that we've got, and it relates to the comment that this gentleman made earlier, we can't meet that challenge by simply saying we're going to just keep recruiting more doctors, more nurses and treating more people, because there aren't the staff there. The staff just don't exist. Even if we had the money to pay them, they don't exist. And we can't just grow them. No. So we have to start thinking differently about how we're going to meet that growth. Historically, the NHS, you could criticise it and say our approach has been build more theatres, build more beds. But I think Lord Darcy's report, and I would urge some of you to read that even if you read the executive summary of it, makes it clear that the NHS cannot continue to just expand to meet the demands that are being placed upon it. It needs to reinvent itself in many different ways. But in terms of do we plan for growth, we have, huge teams of people that plan. Our outpatients are planned down to the day. They take into account the number of working days in the year. They factor in bank holidays. They factor in the growth. They factor in catchment populations. All of those dynamics are fed in. A&E, they even at times can factor in things like the weather and the impact that will have on demand. So we have very sophisticated algorithms to plan for growth. Absolutely.
Thank you. Dan, perhaps if you...
I will carry on.
Yep, please.
Yep. So a little update on GP workforce, but then more significantly, I'll tell you about a thing that we're referring to at the moment as collective action. I'm not going to dwell on the workforce slide because fundamentally it hasn't changed a great deal since I came here 6 months ago, March, and it wouldn't surprise you to think that most of our GP surgeries, and we've listed the Maldon and Whitton PCM, which factors in kind of Longfield and Maldon and Tollesbury, and then Dengie and South Woodham, which would factor in Burnham, Southminster, Tillingham, those practices. Fundamentally, the numbers are pretty much the same as what I said in March, so we haven't really seen much churn. Some people will have left, some people will have joined, but broadly speaking, they're much the same. We do have a new salaried GP at Blackwater Medical Centre, which is significant. You might have seen it, some of you are at Blackwater, because it came out in the newsletter that they're doing. So a new doctor is probably a thing to kind of champion a little bit, because they're really rare. But broadly speaking, we're in much the same sort of place that we were in before. I am going to dwell on this because this is, you remember when I said I'd come back to answering your question a little bit. We're massively trying to attract new, but also retain our primary care workforce. And our primary care workforce is GPs, nurses, therapists, pharmacists, optometrists, all of those things. So just things that we have a fellowship scheme whereby we allow GPs to come into the area. They can become a GP, but they can also work in other areas. They get multi-role jobs. They might come and work for the ICB. They could do some work in public health or health inequalities. Lots of particularly young GPs love that kind of dynamic role. We have a scheme which we call the First Five scheme, and this is a support scheme. So it basically looks after GPs in their first 5 years of practice. So obviously it takes them several years, 10 years in some cases, to become a GP. When they become a GP, this historically were cut adrift a bit. What this does is it takes all the young GPs, new GPs in the area, not all young, some come into it later, but it brings them together as a sort of a group and kind of looks after them and supports them during those first 5 years of their medical practice. We also then have a thing that we colloquially now call the Wise Five scheme, which is at the opposite end, which is GPs that maybe are coming towards the end of their GP career, where they might want to reduce their hours, they might want to specialise, they might want to do different things, and sometimes that can present challenges of staying up to date and those sorts of things. So we have a scheme now called the Wise Five scheme that supports GPs in the latter part of their career. We're trying to increase our GP training practices. It says on the scheme on the side next, I think Fernhouse is a training practice, Longfield is a training practice. It says them in a minute. Being a training practice is significant. Basically means GPs can train other GPs, and one of the best ways of getting new GPs is to be a good training practice. And then a GP has a really good experience when they're training and says, I'd love to come and work for you, and they say, you're great, come and work for us, and that's how you get continuity. So that's a really big thing. Nurses Fellowship Programme now. We've got 21 nurses onto our local programme there, and again, that's a fellowship scheme for nurses. So all of these things are trying to address the point that you said. This is particularly focused on primary care. We have similar schemes in hospitals as well, but this item was more about primary care. So it's really trying to make primary care a supportive environment to work in, and making it not feel that when you go and work in a practice in Southminster that you're over there and you're on your own at the start of your career. Actually, you're part of a community of practice whereby you can work with other GPs, other practices, other experts, and continue to learn. And that's been very, very positive, and you know, nationally people have looked at that. I got my terms wrong. I still called them training practices. They're now called learning organisations. That's the term. But Training Hub, locally, we approve these learning organisations and the educators. So these are the GPs that are qualified to train other GPs. So at the moment, we've got Longfield and Fernhouse within the Witham and Maldon PCN. So GPs for the Maldon town part of the district could potentially train at Longfield or Fernhouse in Witham. And then in the Dengie South Woodham PCM, we've got the Burnham Surgery and the Dengie Medical Partnership, which is split across the site in Maldon and Tillingham, which are I keep going to say training practices. And there we've got 7 educators in the Dengie and South Woodham, and 3 in Longfield and Fernhouse. So in that instance, they'll be the ones that will have GPs that aren't fully qualified as GPs, training to become GPs, can educate them. They bolster the workforce because they do see patients. They're doctors, they're just specialising, so they're already doctors. And many of those, we know that if they have a good experience of that education, will choose to stay in the area. So that's fantastic for us as an area. One of the things that we're trying to do is increase that. Often what you need for that is space, because sometimes it's constraints around space. And if you think Tillingham, Mayland is probably only since they've got the 2 sites and come together. Some of you will remember they used to be the Maylandsea Medical Centre when it was Mike North, and Tillingham was Julian. I can't remember the other GP's name, it'll come to me in a minute, but you know, sometimes when they combine, they get more opportunity there. So so that's sort of positive, and that addresses some of the things that we spoke about earlier. The thing I'm going to talk about now is a thing called GP collective action, and then we'll pause for questions again. So some people have said this is GP striking. It's not strictly striking, it's GPs choosing now to work to rule, and it's supported by their their union, for want of a better description, the British Medical Association, who balloted members, and you can see that they responded fairly unanimously. 98% of respondents voted in favour of collective action, and 70% of members responded. So it's quite a unanimous kind of vote. And in essence, what they were saying was that GPs were going to stop doing over and above what they should safely be doing and what is appropriately asked of them. And examples of that could be chasing blood tests for a hospital, example given earlier. An example of that could be signing off forms for people to be fit to do all sorts of different things, go to gyms, go scuba diving, that stuff. I know some of them charge for those things, but it's still extra that the GP has to do. We're guilty sometimes of putting enormous form filling burdens on them. To refer to Service X, you've got to complete a form, and the form's got 50 different tick boxes on it. They don't want to do that. They don't see that as a useful use of their time. But increasingly, it's things about what are called shared protocols from the hospital. I don't know if any of you have been discharged from the hospital whereby they say, here's your first few days medication, go and see your GP for the rest. And people say, well, why don't you give me 2 weeks? Why is it my GP's job? You're discharged from hospital, but you need a blood test in a week's time to check something. Go to your GP and organise it. And the GPs are saying, why do we organise that? The hospital can do it. So there's a lot of pushback towards hospitals, towards community services to say, in order to allow GPs to focus on their patients, continuity of care and safe working levels, enough is enough of this workload shift. That's fundamentally what the GPs are saying. How much GPs are doing of this locally is very difficult to determine. So some practices have come out with statements saying they're following the action, and one of those is in Maldon. Longfield did that. Equally, some practices have come out with statements that say we're not doing anything according to collective action. And somewhat inconveniently, one of those is in Maldon, and it's next door. Blackwater have said that. That's just personal statements. Tollsbury are not doing anything. Many practices are doing elements of it and saying, actually, this is the bit that was really hurting us as a practice. So to make a point, we're pushing back on that. Is it impacting on patients' experience and the nature of patients' experience within certain practices? I think in some areas it is, definitely. What I would say is when you read some of the letters that have gone from the new Secretary of State, Wes Streeting, to GPs, I think there's an acknowledgement that some of this is a very real challenge for GPs. When you read the Darcy report that I referred to, Lord Darcy makes the point that actually there are elements of the GP contract that are now outdated and need to be revised, and that some of this needs to change. My hope is that with new Secretary of State, the Darcy report, that there will be a reflection of that in the future, and hopefully the need for collective action diminishes. If you ask me, I understand why GPs have felt the need to come to this point. As I say, it's very difficult to quantify the impact because some surgeries are not saying anything at all. They're just simply going about their business, but some partners even maybe are doing more than others. All I would say is if you have particular challenges in your wards, I can be here to be a conduit to that, to find out more. But that's so that you can understand it. They're not striking, they're not closing, they're not going to do that. And they've said outright, they're not going to do anything that would compromise patients' safety. But they are saying enough is enough. And the statement that they often use is they'd heard the GP is best placed to, and then they put ... And the ... could be anything. The GP is best placed to get people back to work. And that's one of the things. Why do we have to sign back to work forms, those sorts of things? So that's what collective action means. So that was the end of the GP section, I think. So at that point, I'll stop, I guess, and take any questions on that one.
Yeah, thanks. Just to clarify, the educators,
Yes.
are they actually sort of active GPs
Yeah.
themselves?
So they have to do additional training and undertake enhanced appraisals themselves to, in essence, to be qualified to educate. And the same happens with me as a physio. Not all physios can teach other physios. You have to have reached a level of seniority to train.
We're not talking about separate individuals.
No.
Councillor Stephen.
Thank you. Yes, I'd like to raise a question that residents raise with me all the time because I'm on the patient participation group in my village, and it's to do with what I call the 8 o'clock rush. Mm-hmm. So I think this is national, that GP surgeries up and down the country now there doesn't seem to be a general method of ringing up and saying, I've got something, I'd like to see someone in a couple of weeks. It's all about the 8 a.m. rush. So you could be suffering with chest pains and go for the 8 a.m. rush. You could have a long-term condition, you're still in that 8 o'clock rush. It doesn't work if you're commuting at that time because you've actually already gone somewhere else, only to be told, yeah, you've got an appointment, you can come back. It doesn't work if you're not very nimble-fingered. We've got the situation where you get through at 8 o'clock and it's already full because there are so many people in the call queue that they know they won't have enough appointments. So you just get a message saying there are no appointments today, and it's a minute or two past 8. It doesn't work if you've been awake all night being ill and you're really trying to sleep at that moment. It just doesn't work on every level. And I'd like to know what's being done to resolve it, because at the patient group I've been asked, well, what would you do? I guess I don't know, because I'm not running health system.
I guess there's an awful lot that I think the 8 a.m. rush is recognised up and down the country, and there is an awful lot being done to try and address it. I mean, two things. What I'd suggest is either me or somebody else can come along to the patient group with you and explain, and there will be a number of things specific to Tollsbury. Not all surgeries are doing exactly the same, which is why I'll give a sort of general answer now. But I'm happy to pick up with you. You can drop me an email. I'll come out when there is a PPG and we can do some specific stuff around Tollsbury. I think a number of GPs are recognising this. So a lot of people are now adopting what's called total telephone triage. So in essence, a number of our practices, and all people, whatever time you call, will ultimately get a call back or will be assessed by a GP, and they will determine when and how you're seen. It's quite a change for patients because in some cases you simply leave a message and the GP will get back to you. It's quite a change for practices because it fundamentally changes the way that they work, and Many of the practices that do it, or PCNs, they do it across clusters of practices. There are doctors that are essentially doing that on a shift, for want of a better description. So that's all they do for a period of time. And what they'll determine is you need to be seen urgently, or today, you need to be seen tomorrow. Actually, you can be booked in 2 weeks' time. So they start controlling what they do a lot more. Some are doing that electronically. Blackwater, for example, now. So some of you here might be Blackwater. Blackwater, we've got an e-consult service. You can actually do that on your phone. You can go on and say what's wrong with you. You won't necessarily get a response immediately there, but within 24 hours, somebody gets back to you, and quite often they'll say, we're booking you an appointment in, and they'll give you the time and the date and the appointment. In some cases, that could be in the future if it's something relatively non-urgent. In some cases, it may be sooner. The only thing I'd say, just as well on other things that you'd said there, I mean, certain things, I mean, chest pain, I'd encourage people never to use. You did mention chest pain. Don't phone your GP at 8 AM if you've got chest pain. Phone 999 if you get chest pain, or certainly 111. Algorithms should pick up some of those things. But it's nationally recognised, Councillor Stevens. So, like I say, I'd rather do something specific with Tollsbury, but for others, I'd say expect to see those changes in the way that you access services. So certainly I'm a Blackwater patient. So for me, I recently, you probably tell that I'm a bit under the weather, but I recently have used the e-consult service, and it worked pretty well. What should happen, and I know some of you will immediately say to me, that doesn't always happen. I know it doesn't always happen. I'm saying what should happen is ultimately the phone should still be there and should be a viable option for those people that can't use online. I appreciate using an app isn't for everyone. I appreciate online booking, e-consultations, all of those things aren't for everyone. But the ambition from the GPs is that if you can, the term they use is channel shift. So if you can get the likes of me using e-consult, and you can get the likes of some of us in this room shifting to online consultations, but for those people that there is no other mechanism other than using the phone, that actually they can get through. But I know it isn't right everywhere. Not all surgeries are at the same point in time. I'll double check with Tollsbury because I wouldn't want to say off the top of my head, but the other thing is a lot of them move into what's called cloud-based telephony, which is call stacking and automated telephone systems. That's been backed nationally, and there's money behind that. Whether Tollsbury's moved, I don't know off the top of my head, Emma, I'd have to check. But I would continue that offer for any of you that are in a particular ward. If you've got a particular question with your surgery, get in contact with Paul. He can contact me. We can do something local where we do something a bit more bespoke, because it's not the same thing everywhere. And some of the surgeries, particularly the smaller ones, places like Maldon would be a good example. What they offer may be quite different to a bigger practice like Longfield or something like that. So.
Yes, talking of the NHS app, I came across a thing on patches.
Yes.
Which, when I first saw it, I thought this is marvellous, what I've been waiting for all my life. And then, but unfortunately, Fernhouse only operated between 1 o'clock in the morning and 6 o'clock, between 1 and 6 in the morning.
Okay. I don't know.
That seems rather bizarre.
Yeah, I don't know about Fernhouse, so again, I could check into that one. I think a lot of them are quite new, and I suppose what I would say is I've not encountered many GP surgeries where they've put these, and they get the systems off a national framework. So there are different systems, but I think they're procured via a national framework. So
yeah, I got the impression that the national Furness had to sort of book into it.
Exactly. Yeah. Some of them, it takes them a while to optimise it for the way that they work. Right. The other thing that I would say, based on my experience of it, and actually there's one of our Chelmsford practices that did a sort of masterclass on it for other surgeries. I hesitate saying this, but I think some GPs, some practices were maybe under the impression that you sort of install the software and somehow miraculously it fixes everything. It doesn't. It requires a fundamental change in the way the practice works as well,
right,
to optimise the use of the software. So it's not just a case of using the new telephony system and using the online booking systems. You have to change the way in which you work as a practice. And the practice in Chelmsford that sort of taught me about this, as I say, actually they said it was quite a eye-opener for the GPs, and it's required a very different way of working.
Right.
Now they've done it, they would never go back. Right. You often do get a bit of patient pushback originally as well, because what it ultimately means is the GP or senior clinicians within the practice will ultimately dictate where people end up and when they end up there based on clinical need. And sometimes there's a mismatch between people's clinical expectation and people's clinical need. So Paul gets a bad back, contacts eConsult, gets booked in at Blackwater, and he sees me, the physiotherapist, because it's been determined that I'm best placed and soonest available to treat a bad back. But Paul may say, I didn't want to see a physio, I wanted to see a GP. The idea is that the people that you do see are clinically skilled enough to be able to treat your condition. That could be a pharmacist, could be a paramedic. Many patients are very comfortable with that. They get good service, they get good feedback, hopefully they get good treatment, they get better. They're very, very happy with it. Some patients push back, and it is a change. So it's difficult in different areas.
Councillor Spencer?
So that was quite fortuitous talking about people in all those other roles, because going back to what you were saying about training and trying to attract or develop more people locally as health professionals. I just had a question to ask with whether or not, and you mentioned Anglia Ruskin, which is great, but I have a background where I worked for quite a long time in further education, and particularly in access to HE and adult training and retraining. So I just wondered, does the ICB sort of engage at all with people kind of lower down the pecking order than universities? So, and I've written some notes here looking at FE colleges as well as schools, of course, but adult learning facilities and, education charities. For example, one of the major access to HE charities is actually based in Colchester, so it's nationally, so it's quite local. And that kind of really struck me, because I found out I moderated there at one point, but I found out quite recently that the two access to HE courses, which were over the library in Maldon, which were both about access to health professions, have both gone. They've been moved by Essex, who runs them. So, but Chelmsford still have a lot on, for example, a lot of those types of courses. And I just wondered if the ICB ever engages with those, organisations to try to get people on board, lower down, for want of a better way of putting it, lower down the chain than university.
So absolutely, we do at all of those levels that you referred to, schools in terms of careers fairs, those sorts of things. A good example, appreciating that Writtle have just merged, yes, but prior to merger, we did a lot of work with Writtle as both Writtle's postgraduate and I can't remember the further education and higher education, I think is the term they use, isn't it? And we work with them on both of those. And in some cases it is for, I think the difficulty sometimes for clinically professional qualification. So to be a physiotherapist, to be a nurse, to be a doctor, you've got to go to the designated places. But there's now increasingly opportunities for non-clinical professional roles within the NHS. So a good example that we worked with Writtle on were social prescribers, whereby people can work to help people in communities, point people to different sort of social opportunities. Massive part of our workforce, growing, hugely valued by particularly primary care. Actually, we did some great work with Writtle University, Writtle College on that. Writtle have subsequently merged, so that maybe now isn't as good an example as it was, but absolutely we do all of those things. I think we've also got to maybe think about some of our recruitment policies, because I think some people have said there are barriers to recruitment within the NHS that we need to expand upon. But further than just the different organisations, we're also looking at increasing our ability to recruit people with barriers to learning. So good examples there would be people with autistic spectrum disorder, that sort of thing, where actually they can provide huge contributions to the NHS, but sometimes find barriers to access. So, yeah, many of those things, Paula, we do that.
Yeah, that's really useful. I just wonder if it's something that we could work in partnership with sometimes, is where those opportunities exist, is perhaps promoting them or, that kind of thing locally, so that people are aware.
The other thing, we have access to the apprenticeship levy as well, like others who are using the apprenticeship levy and things like that. It'd be appropriate. It's not for me to point, sorry, I was pointing. So.
Councillor Driver, and then we must move on.
I'll try and keep this quick. I'm actually a member of the Longfield Patient Participation Group, so okay. I should acknowledge that. So just two things. One in relation to the pressure that GPs feel they're under. Mm-hmm. In the meetings that we've had with them, they have felt very, very pressurised. and one of the impacts has been that the number of appointments per day per GP has reduced, because actually this is part of the working to rule, as it were. So it is having an impact, because the number of appointments available are less. And I'm just hoping that some of these other things that you're doing to try and put an arm round GPs is hopefully going to see them feeling like they are being supported, and that actually they can return to some of their old practice, where actually they were more engaged than they are at the moment, though I take it that they're not actually on strike. The other element I just wanted to mention was about the way in which the appointment system works. Longfield runs patches, and actually initially we had the 8 o'clock problem, and at 8 o'clock the hammer would come down, and what we were saying to them as a patient participation group was, this doesn't work because you are saying you're wanting to triage. You are only triaging the people who managed to hit the button to get in by 8 o'clock. So whether you've got an ingrowing toenail or a heart attack, I'll take your point about heart attacks, but actually there is no triage, because you're just triaging those people. So they're learning to work with it better, and they're opening it up longer so that actually they can start triaging. So they get to hear a range, and then they start making decisions about whether it's that day or the next day or a week's time. And that is beginning to work better. So I think, as you were alluding, as people get to understand how these systems work, I think they're getting better.
And that's good to hear. And in order to open it up, I think often it's fear of being overwhelmed that your term brings the hammer down. And as I said, sometimes when you open up that demand, you've got to be prepared to adapt and acknowledge. Like I say, Mike, the GP that I'm referring to, would say, they do it on a shift basis, but he'll spend a day that he's just doing that to meet that demand. The net result, though, is that ultimately it results in a better system for them, but it takes a bit of pain to get there for them. And then the final bullet point there actually specifically addresses what you said about Longfield capping their capacity. Capacity that they're capping it at is what the BMA recommends is a safe level of patients for a GP to see. So when you were saying perhaps like we might see them return to what they did before, I think many GPs would argue that they should never return to what they did before, because actually by sticking to that number, they can give patients a sufficient amount of time to give clinically good, effective service, not have the kind of one problem per consult, actually really get to the bottom of the problem, manage long-term conditions. I think the job of me and many of my colleagues and other people within the NHS is to create systems whereby the GPs can meet demand but stay at that safe capacity, not feel the need that the only way they can meet the demand is by fitting in 40, 50 patients per day, because that's evidence-based to increase errors, to result in reduce patient satisfaction, and it increases GP burnout, what we were talking about earlier. If a GP sits there and sees 50 patients a day, he or she won't be happy with the service that they're giving, patients won't be happy, errors increase, and that leads to disenfranchised GPs who want to leave the profession. So it's difficult, but hence I can understand why they do it. And I've worked clinically for a lot of my life, and when you reach a point where you're inundated and it's just bang, 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 bang patient, you get to that point where you know that you're going to make errors, and that's not a safe place for people to be. So it's a difficult compromise, but I think the job of those systems is to try and mean that this is a safe way for GPs to work in the future. It's a challenge.
Okay, thanks, Dan.
Last bit, almost there, everyone. Thank you. Was just a little bit about winter planning. You probably will smile because you know that I always come and talk to you about winter planning pretty much every time of the year. But we're always preparing for winter in the NHS. But winters have been particularly challenging in recent times, obviously, particularly since the pandemic and the bounce back from that, getting things right. We're undertaking a campaign, Be Prepared for Winter, and the key areas are listed there. And it was positive to hear some of you saying before the start that you've had your flu or your COVID vaccinations. The other one that some of you might not have heard of is there this thing called the RSV vaccination. So certain people will get a thing called an RSV. It stands for respiratory syncytial virus, but it's a virus that causes respiratory illness. Has had a significant impact on the NHS in recent winters, and actually certain people can be protected from that. So, you know, again, as individuals, but more significantly within your particular wards and within your kind of sphere of influence, encouraging people who are eligible for vaccinations to uptake the vaccination is a massive positive for the NHS. Targeted flu vaccination in people is one of the single biggest evidence-based interventions that you can get to reduce respiratory illness. So anyone who's eligible for the flu vaccine, encouraging them to have that it's a really good thing to do. We do a lot of advice, and it's all out there online and in various formats about self-care, just simple things like keeping a well-stocked medicine cabinet, what to have in it, what to self-treat, those sorts of things, so that if you do have those things that you can treat at home, that you're able to. We're promoting hugely pharmacy first, so wherever possible people go to their pharmacist. Lots of pharmacists now can prescribe, they have treatment rooms or consult rooms in them. There are many minor illnesses that a pharmacist can treat as effectively as a GP because they're relatively simple, and so it's trying to get people out of that habit of default thinking I need to see the GP when actually a pharmacist can see them without the need for an 8 a.m. rush. Not only is that positive for the individual, but it reduces the burden on the other channels. Big focus on mental health. We do see a significant rise in certain mental health conditions in, as it says there, the kind of colder, darker months. We work brilliantly with yourselves via One Maldon for lots of things that we do there around kind of winter warmth, safe spaces, shared spaces. Again, particularly for our elderly, particularly in places, socially isolated places. Dengie is a good example. What we don't want is elderly folks sort of sat inside, not socialising, not being kind of checked upon during the winter, because that can all lead to problems. And we are doing lots of work with colleagues in the council already on that. I don't think there's an ask of me there. I think it's another one where in future we could probably tell you, or certainly you will know yourselves. And then little bits there around kind of falls prevention, and we do some work in this area with Tri-Services as well. So it's not just the NHS here. People like the fire service help us enormously. They do a lot of work in terms of helping people to sort of stay safe in their own homes, just looking at simple things like falls risks and stuff like that. So all of those things, none of them in themselves are a silver bullet, although that said, vaccination is a massive protection for the individual and for the NHS. But those things combined can reduce the burden on other services. Sorry, I'm losing that. When the slides come out, the blue bit you can click on, so it takes you to our web link, which is the central hub where you can get all the winter information. And as it says there, we'll share via One Maldon all the localised information, and actually vice versa, which we've done in previous years, whereby Paul and his colleagues will tell us all of the work that you're doing as an organisation, where we've got, like I say, our kind of warm environments, our kind of communal environments, all of those sorts of things. So all of that stuff is happening. At that point, Chair, I'll stop again and take any questions on that, and then I think that's it for me. So.
Okay, thank you very much. Anyone? Councillor Morley.
Yeah, thank you. I'm not sure if I'm digressing slightly, but you were not drunk, so I've seen that film before. You were saying about prevention. I wonder if there's anything in the pipeline about domestic science in schools with diet and things. I heard it on the radio today, funny enough, and it's probably, young children, pupils, whatever, they understood the climate emergency and things like that. I just think if we could start young about, just vegetables and things like that, and surely diet is going to help save a fortune.
If you look at that bottom one, I didn't actually read it out, but boosting immunity, highlight the importance of a balanced diet, staying active and staying hydrated.
They need iron. They're lacking iron, I've heard. Yeah. A lot of people, particularly girls.
I mean, it's not just the young. It's all ages at the minute, and it is.
And it was stopped, say, 30 years ago.
It is
carried on.
It is compounded a little bit by the challenging cost of living for some people that nutritionally balanced.
It's cheaper
food
to
is-
make a shepherd's pie than jolly well buy one.
Yeah, so that's I mean,
Mince.
if you know that, you know
If
that.
you know
not
how to
everyone
cook.
does. Yeah. Now, are the NHS doing that? No, we're not at the minute, and that goes into that realm then of secondary prevention. But I think the need is there. I don't think it's just diet. I think it's physical activity is massive in that as well. Boosts mood, boosts immunity, and as it says there, simple things, staying hydrated. One of the most significant reasons that we see for elderly folk getting admitted over winter is dehydration, and it's that concept of being cold. Maybe being a bit under the weather, not getting up, not drinking, that often will then lead to a urinary tract infection, that leads to confusion, that leads to admission. And that's that spiral that I was talking about earlier. And many of you nodding, we've seen that in family members or whatever. So it's a good point. It's raised, it's probably beyond me to be able to influence that, but I don't disagree with it. I don't disagree.
But being a farmer, you tend to do stock judging on people.
Yeah.
And you see, do you see sunken eyes, the colours, they just look anemic. You can tell straight away, not that they're good stock, but you know, that's a good provisor to go by. And I thank young farmers for my stock
Feeling ever so
judging.
paranoid now as well. I'm thinking, geez, I've been under the weather for a few weeks and I'm working for the NHS. I need to. You're right. All of those things they do help enormously. We were. I as a part of another job, I work for an organisation called Active Essex as a non-exec, and we were talking at our board meeting today. You know, physical activity of all forms, social activity of all forms, is so important for people. So these things, they do make a massive difference. I think that's where the likes of One Maldon can help. We do have local school teachers, for example, as part of the One Maldon partnership. We have some of the young farmers as part of the One Maldon partnership. And actually, you know, just taking that as an example, the work that we're doing out in the Dengie with the farmers around suicide prevention, fantastic. So that secondary prevention, I think, is where the partnership work that we're doing really comes into its own. So.
Thanks. Councillor Stevens, did you have?
Thank you. Yes, so to move away from that slide, if I could just ask a different question completely, please. So we've just sat here with the meeting with the NHS and nobody's said St Peter's, so I'm going to say St Peter's. I'd like to understand, please, Halstead. How can I understand what's happening in Halstead versus St Peter's?
Sorry, you're saying Sybil Headingham, you're saying Halstead.
Oh, you're talking about the same.
I am talking.
facility,
I thought
yeah.
it was Halstead actually, so apologies if it's Sybil Headingham. And I actually expected Councillor Spenceley would be raising a question on this. So if you want to add anything to what I've just said, please do. Thank you.
Yeah, no, I mean, I think I just hope, and Dan knows because I've said this to him at a different meeting already, that I hope that the Sybil Headingham model will be used at the working group to look at how we could possibly bring something forward here. That's my hope, but I wasn't going to get into that tonight because I didn't.
Yeah, I guess it wasn't strictly speaking relating to these things, but I mean, so we can learn a bit from this. Sybil Headingham is a GP surgery replacement scheme. That's all it is. There's nothing more to it than that. No. If you let me finish.
Well, yes, please do. Because it has it's caused a lot of interest.
So it's a GP replacement scheme. It's 3 very old surgeries that are very small and very much at the end of their serviceable life, being replaced with one single GP surgery for that area. We've had similar schemes. Southwood and Ferrers, for example, was a similar scheme, GP surgeries. It's GP only, so it's only a surgery. It doesn't replace a hospital and it doesn't provide space for services from Halstead Hospital, which you could argue is in some ways analogous to St Peter's. So there is some learning perhaps that we could take from it. I mean, we did work very closely with Braintree District Council and they've provided the land for that. But I would hesitate to say that it's translatable to St Peter's because St Peter's is a much bigger entity, and we're talking there about diagnostics, outpatients and all of the other services in and around St Peter's. Sybil Headingham is purely a GP replacement scheme. And actually, the learning from Sybil Headingham is probably far more applicable to the Haybridge garden development, so the Westcombe Park development, which is more directly comparable because that's a direct replacement for 2 ailing branch surgeries in Bentals and Goldring Avenue into a new GP surgery. So we probably have learned and continue to learn from Sybil Headingham, from Chelmsford, from other areas about how we can navigate in GP replacement. But I don't know that Sybil Headingham in itself tells us a huge amount about what we might do for St Peter's. We learn all the time, so we're going to learn some from it, but it's quite small scale as well in comparative in terms of size. So,
Yeah, can I?
Yeah.
Sorry, Dan, I think you've got your.
I've kept it on the whole time.
Oh, right. Oh, that's okay. That's okay. Oh, that's all right then. Okay. So, so it was just that Sybil Headingham, the surgery was presented, for example, at Hosk, that it would have some other stuff there. I wasn't saying that it was comparable, but I thought we were looking at that it might be a model that we could use to develop something here that would bring those other services there, because there was talk, for example, of, well, it was in the report, that even minor injuries were a consideration there, as well as some day surgery and some visits by consultants and some not actually birthing, but, antenatal and postnatal care. So I was just thinking there that, I wouldn't dismiss that some model like that. I know that the desire is to keep a hospital here, but I still think that there might be things we could learn from that to bring about something that was at the centre, that bigger than that, perhaps, if that's what's needed. But obviously what I think we're saying is that we're facing here that we're losing everything, and that's the key to it, really, Dan. I wasn't going to bring it up tonight, but I just think it would be something that would be useful if the working group looked at it.
I'm happy to share everything that we've done on Sybil Headingham with the working group. I personally don't think it's the best model that we would use for learning. Sybil Headingham's a very rurally isolated community. Why anyone would choose to live there, I don't know. But Paul lives there. Sorry, by the way. I was only joking because I was only joking because I know Paul lives there. So apologies. I didn't appreciate everyone. But no, Sybil Headingham. And most GP surgeries will do so. For example, Dr. Geremmeyer will do minor surgery in that clinic, and GPs have what's called a minor injuries les, so many of them will do that. I personally think we need to look at at Maldon as needing a more complete solution than a standalone GP. So I think it needs to be more than that. I'm happy saying that. I think we've acknowledged that we need to be able to replicate the outpatient services at a scale that is beyond the like of what we're talking about at Sybil Headingham, absolutely. So, like I say, we can learn some things from it, but I think we need a bigger, more complete model for Maldon than that. I think there is a translatable bit for Haybridge. Yes. There is definitely a translatable bit for Haybridge, and I wouldn't underplay the significance of replacing the 2 Haybridge branch surgeries with what's to come in Westcombe Park, because it's going to be a tremendous asset for the town, which I think will make a huge amount of use for. And if any of you know, some of you may know Bentals and Goldring House, they're not great assets as they are at the minute.
Okay. If no one else, then Dan, thank you very much indeed for coming and giving us the most interesting talk and also answering our questions so thoroughly and so well. It's always a pleasure having you here. We look forward to you returning soon. Okay, so moving on then to agenda item 7. Any other items of business that the chairperson of the committee decides are urgent, and I'm pleased to say there are none. So I close this meeting at 21:03. Thank you, members.